words.
Okay, a very warm welcome to everyone. This is our second webinar.
Please. We are live now.
Yeah, can we go ahead?
Yeah. So,
hello.
Dr.
A very warm welcome to everyone, all the participants. Yeah, and this is our second webinar in our webinar series after the COVID era. And I'm sure it's going to be really thrilling and interesting with likes of Dr. Sangwan and Dr. Chana Mazumdar, Dr. Ohri, and Dr. Geeta is there. So not only will be learning so much, but will be totally mesmerized by their talks. And without much delay, because Dr. Sangwan is short on time, I'll hand it over to our dynamic General Secretary, Dr. Ajay Arora, to initiate the proceedings.
Thank you, Dr. Atul. It's my honor to have Dr. Virendra Sangwan for the masterclass. This is the second webinar for 2021. And this is the first masterclass. Who else but Dr. Sangwan? So, he's got a long list of awards and huge credentials. So I'll just make it short. Dr. Sangwan was initially trained at Rohtak and Maharishi Dayanand University, followed by his fellowship in L.V. Prasada Institute. And then he did his, spent some time at Orbis for about 18 months, followed by the path-breaking fellowship he did with Dr. Stephen Foster at Massachusetts Eye and Ear Infirmary. And Dr. Sangwan then came back and did a lot of things at L.V. Prasad in India. He set up the limbal stem cell biology laboratory, and with Dr. Geeta Vimaguti was instrumental in making one of the largest clinical human trials on limbal stem cells transplantation, which today is being followed all over the world. Dr. Sangwan has got numerous awards to his credit: the P. Shivareddy Vengalra Award, Kala Rangachari Award, and Shanti Swarup Bhatnagar Award, plus the DBT National Technology Award. He's with us in North India at Shroff Charity Eye Hospital as the Innovation Director. I have known him since many, many years. He has got, he's absolutely down to earth, very pragmatic, very straightforward, very rustic, and comes down to the point immediately. We welcome you, sir, and I'm sure that this masterclass will be one of the most enchanting we have had with the Noida Ophthalmic Society. And I request Dr. Uma Shridhar, who is the cornea specialist at Eye Care, to take over as moderator. Dr. Virendra Sangwan, sir. Dr. Uma, please.
Yeah, sure.
Thank you
yes,
very
sir.
much.
The floor is all yours, Dr. Sangwan.
Thank you very much, Uma, and I'll just share my screen. Just give me a minute. So I would like to thank Ajay and Noida Ophthalmic Society for inviting and giving me this opportunity to share views on the simple limbal epithelial transplantation, which is a technique which is now in the clinical practice. Let me share a few stories of patients which I have treated over the years. This is a 75-year Gujarati gentleman who lives in Canada, and he is an engineer, but immediately after going to Canada, he met with an accident at work and went blind in both eyes due to bilateral limbal stem cell deficiency. Then multiple consultations and treatments in US and Canada found no relief. He flew to in LVP in 2006. His daughter flew down from Switzerland, whom he has never seen since birth. and C donated the limbal tissue for limbal LO-CLET. After doing the CLET with systemic immunosuppression following PK, he gained almost 20/40, 20/30 in one of the eyes. The other eyes we did not attempt. This is another gentleman from Netherlands.
I didn't believe what I was seeing. I had a completely clear sight. It was unbelievable.
So similar story like this gentleman Gujarati, but this is a Caucasian from Netherlands. Tried very hard to find a solution for his problem, and in his case, we did a autologous cultivated limbal epithelial transplant, and he still follows with me at Seraph, and ever since we did a limbal transplant in 2007. This is a girl from Delhi whom I had operated for autologous cultivated limbal epithelial transplant followed by PK in 2001. And now she was 9-year-old girl at that time. And today she's a 20+ year follow-up and doing very well. And just last week, she called me to invite to her wedding. So I'm very delighted that these limbal stem cell transplantation have such an impact on people's life. This boy was brought to us in LVP for removal of the left eye because the father took to different doctors and they said nothing can be done about it, and the boy stopped going to school. So we offered him a new technique called simple limbal epithelial transplantation, and this is what immediately after about 6 to 8 weeks post transplantation this boy improved to. And this is the pre-op. 6 weeks post-op, then he underwent another top-up SLET, followed along with the conjunctival limbal autograft and the histopathology of the penis. So what are the limbal stem cells? What is the pathophysiology? I'll touch upon briefly. So the ocular surface physiology, essentially there are 3 elements: preocular tear film with all its components, surface epithelia, surface ocular surface sensitivity. I'm not talking about corneal sensitivity, but ocular surface sensitivity, because that is essential for normal functioning of the tear film and epithelia. And this is the component, the compositional factors and hydrodynamic factors for the ocular defense mechanism, which are coordinated at the mid-brain level through these 2 arcs, reflex arcs controlling the lid blinking and the tear secretion. Through the neural pathways. So therefore, the stable tear film is essential for healthy ocular surface. Healthy ocular surface is essential for tear film. So unless we understand this aspect of our surface physiology, attempting any ocular surface surgery would not be very wise. These are 2 pictures of 2 different patients. On the left side, you see a scarred cornea with some vessels. On the right side, you see a fibrovascular penis. On the surface, it may look like both are limbal stem cell deficiency, but they are not. The left one is a diffuse corneal scarring, and the right one is a following chemical burn. So it's very important to be able to diagnose the limbal stem cell deficiency and then treat accordingly. What is limbal stem cell deficiency? It is the destruction or dysfunction of the limbal stem cells, which are the transitional zone cells at the limbus, and any death or destruction causes the conjunctiva to grow onto the corneal surface, which you are seeing in the video clips. And because this conjunctiva is not normal to the corneal surface, it may break down, it may cause ulceration, persistent epithelial defect, and loss of vision. So the typical sort of sign is the fibrovascular penis growing onto the cornea. This can be the classification can be different, idiopathic, congenital, or secondary or acquired, and the different indications, different sort of etiologies present. I'll show detail about the etiology. It's a very good study from India. So therefore, understanding the etiology and then classifying the LSCD is very important, because the extent of damage, severity of damage will dictate your prognosis and the need for supportive surgical treatments and other treatment. If, like, for example, if there is a systemic disease, underlying autoimmune disease, you need systemic immunosuppressive treatment. And these are the difference between dysfunction versus distraction. So here in the lower panel, it is the Murren's ulcer, which has destroyed the peripheral cornea, but central epithelium is maintained. While in the VKC, limbal form of VKC, you may see this dysfunction in the beginning, in the early stages, and the corneal epithelium may still, or the limbal epithelium may still work. So make this distinction, and in both these cases, surgery may not be required as long as the patient is able to see from the central cornea. I present to you a very large study done in LVP in different campuses between 2005 to 2015. Of total number of patients were 1871. Patients were 1331, and eyes were 1871. If you see, majority, or the 66% were males, and 60% were unilateral, and 40% were bilateral. The age distribution, median age was 24. So it affects young adult male who are active, and they are more prone to injuries because of the work-related injuries. The visual acuity, majority of these patients presented with 2200 or less. And the extent of, when you look at the cloak hour, number of cloak hours affected, over 80% of patients presented with total limbal stem cell deficiency. And this may be biased because it's a tertiary care center based study. The causes, very interesting. If you see, a very large number is due to ocular surface burn. Then number 2 cause was VKC. Number 3 was Stevens-Jones or toxic epidermolysis necrolysis, and iridia, mucous membrane pemphigoid, and others. And if you look at the identifiable causes, ocular surface burn is the most common cause of the unilateral limbal stem cell deficiency. Bilateral, on the other hand, is mainly due to 3 conditions: ocular surface burns, the VKC, AKC, and SJS-TEN, and rest of the minor causes. Within the chemical burn, the most frequent is the lime burn, then followed by thermal, cement injury, caustic soda, and variety of other acids. This paper was published in American Journal of Ophthalmology. And then you may have the variety of presentation due to chemical burns that I showed you earlier. So in etiology, this analysis of demography and underlying causes is the largest database from anywhere in the world. And majority of patients affected in LSCD in our setting are male in a productive age group. LSCD leads significant visual impairment, and significant percentage of causes are preventable, mainly because these are chemical burns. And the total LSCD outnumber those of partial LSCD. Overall, surface burn is the commonest cause. The second and third commonest cause are VKC and SJS. And alkali burn remains the commonest cause of ocular surface burn. And that is what we have published in different studies as well. So for unilateral, it is secondary to ocular burns. Bilateral, it is fundamentally because of VKC and ocular surface burn, leading causes. The treatment of limbal stem cell deficiency essentially is surgical. So the surgery can be classified based on the source of tissue. If it is bilateral, it may be allogenic tissue. If it is unilateral, it is autologous, and it can be ipsilateral from the same eye or from the contralateral eye. Or technique also, it can be based on technique like direct in vivo cultivation like SLET, ex vivo cultivation like the CLET, and without any lab manipulation, you can have conjunctival limbal autograft, CLAU. So these are 4 different techniques or different ways of treating limbal stem cell deficiency, and I'll briefly be referring to them as I go, but majority of the rest of the talk will be focused on SLET. So initially when we started, the way we grew the cells was unique, and it was designed and prepared in LVP by us, which is a explant culture without any 3T3 fibroblasts, without airlifting, without fetal calf serum. 2 weeks, you get enough tissue and then you grow. And based on that, for almost 10 years, we published a large number of papers in different journals with excellent outcomes. However, in pediatric LSCD, we found that success rate was very poor, and we did not understand why it is so. Like 40% success rate in pediatric LSCD versus 75 to 78% in adult LSCD, primarily caused by the surface burns. The drawback of SLET are very obvious, that you need a very expensive clinical grade laboratory, expense of growing the cells, and then you need 2 surgical procedures, one for taking the biopsy, the other after 2 weeks doing the main surgery. And then another downside is the pediatric LSCD, the outcomes are not very successful or not very acceptable. So then we came up with this technique in 2009, 2010, wherein we took the biopsy and we combined our learning from the SLET and CLAW, that you take the biopsy, cut into pieces, and then transplant directly. And this paper was published in 2012. The surgical videos I'll show you later. And so what are the good cases for a beginner, for a SLET? My recommendation is you choose a chemical burn induced unilateral LSCD, total or partial, without not much simulacrum. Adult or children with Lyme injury, avoid acid injury in the beginning. No underlying systemic autoimmune condition, and the other eye should be having good limbal palisades. The cases one should avoid are bilateral cases in wet eyes, where you need allo-SLET with systemic immunosuppression. Patients with severe SJS, OCP, Sjogren syndrome, GVSD, unknown causes of LSCD, please avoid in the beginning. Poor surface with decreased ocular and corneal sensitivity, post-radiation, post-OSSN excision, local or systemic immune-mediated diseases. So these things are a little more complex. So in the beginning, unless you have good experience, don't do those cases. Essential requirement for doing the SLET for any surgeon, the surgeon should be familiar with some surface surgeries, especially use of fibrin glue or suturing the amniotic membrane. Visual potential in the eye or eye to be operated, unless it is being done for cosmetic enhancement. Proper workup of patient and informed consent. Surgeons should be familiar with post-operative events and different appearances in the post-op period. And BCL is essential at the end of the surgery, and do a tarsorrhaphy when in doubt or in selected cases. Another important thing that you should remember is, if the surface is dry, like what is looking in Steven Johnson, please don't do any surgeries unless you have an emergency. In ocular surface burns with wet eyes, surgical outcome generally is very good, especially with the line burns. So the indications of SLET would be unilateral, bilateral LSCD, total or partial, with decreased vision, or patient is very symptomatic or cosmetically unacceptable. LSCD is a surgical disease, and medical treatment generally does not help. Cosmetic enhancement, even if prognosis is poor. So I would recommend that in the beginning, if you're a beginner, don't do cosmetic SLET. Do it only once you are very experienced. And the SLET is also done as a preventive in cases of OSSN, recurrent pterygium, to prevent recurrence, PED, acute surface burns. The surgical technique, how it evolved. Look at this video of in 1889 by Sefer Singh and Kent Kenyon from Mass and Ear, how they start taking biopsy. They start from the clear cornea, and then they partial lamellar dissection backwards towards the limbus, and then they will dissect into the limbal area and the conjunctiva. If you see the technique which I have evolved and practiced over the years, is the completely opposite. And the rationale for that is because if you start from the conjunctival side, you have very clear-cut anatomical demarcation of the planes. So I feel that the plane you find from starting from the conjunctiva is far better, more predictable, and you know how deep you need to go, as opposed if you start from the corneal side. So my recommendation is the technique of taking biopsy is starting from the conjunctival side and not from the corneal side. And this is a very typical case for me of a total LSCD. So this is how you start your pannus dissection. And obviously you have done the diagnostic testing, you have done the imaging to understand how the cornea looks. You must have done ASOCT, UBM, B-scan, other things to satisfy yourself. And then start dissecting from the periphery. Same reasons which I explained, that from the periphery, from the scleral side, you can find the plane. And at the limbus, be very careful and don't remove the corneal fibers. And because you generally find a plane of insertion of the pannus. Once that pannus is cleared, you can do gentle cautery to achieve homeostasis, then the amniotic membrane, and then you do the transplantation. And this will be a complete case. Harvesting the limbal biopsy, again starting from 4 to 5 millimeter behind. And this cones we are using as a handle, so that we don't want to touch the limbal stem cells at the limbus. And this is more of a handle. Then you can reposit the cones back, and after harvesting the strip. This is a new innovation that I did, is at the site of the limbal biopsy, you can take a snip biopsy from other site and put the explant at the donor site. And then it's the patient's other eye, you start working. You can use it's a drop or two of brominidine before the surgery, 10-15 minutes. That will help you in chemo cauterization and will reduce the bleeding. So the pannus dissection is an art, not much of a science, and it's more of surgery you learn by doing it. But respecting the anatomical planes, histological planes will be very, very helpful. And then you clean up your ocular surface. Here, the corneal surface is irregular because there must have been a PED. And this is the fibrin glue, the fibrinogen part, the thick part first, and you put the other part second, and then just bring your amniotic membrane and iron out without any wrinkles. Preferably with an iris repositor. And then you cut your pieces of the limbus. You can cut in 3 different ways. Either you can use the scissors and forceps like this, or you can use a back of Teflon block with 15 number blade, or third you can use for you is a fine, and you make them to 14 or 16 pieces, distribute equally. And if the cornea is very good, very clear, then don't put the explants in the center of the cornea, 3 to 5 millimeter, put only in the periphery. The general questions for beginners are whether I should do a local, topical, or general anesthesia. My advice for adult patient, cooperative patient, do under a paliperbal block, not topical, because the surgery per se is not very invasive, but it's very delicate. Because eye moving, you can tear the limbal biopsy, and that will destroy the whole surgery. General anesthesia is for pediatric age group, for adults who are not able to cooperate for local anesthesia. Sometimes I did not pay attention to these things, like should I take limbal biopsy first or I should do pannus dissection first? Because some of the fellows point out to me, sir, first we want to do the pannus dissection, because if we end up in a problem, perforation, so we may not waste the biopsy. Perfectly reasonable. I always do limbal biopsy first, because I have been doing like that, and I'm able to manage my situations most of the time. But if you do encounter perforation during the dissection of pannus, do not panic. You can either leave the area of perforation to the last, and if it's big enough, you may want to use some sort of a patch graft or a Tennant's patch graft or a TABCL, or then if it is too big, then you may think of converting into a PK. Biopsy and how deep you should go, I explained. Follow the anatomical plane, start from the periphery towards from the conjunctival side. Then you have a conjunctiva, you have Tennant's capsule, then you have sclera. So these anatomical planes are so clear that you cannot go wrong. And then follow those planes to the limbus and into the cornea. Another question is, can I combine PK with PKP or LKP with SLET? Generally not. If you are forced because of the intraocular situation, like you have a too thin cornea, or you perforated, or the pre-existing perforation did not anticipate, then it's perfectly fine. And if you have a PK with which is failed with LSCD, which one you should do first, SLET, PK, or combine. Depending on the patient's need, how far he comes from, how much time does he have, I would recommend that we do SLET first, see the outcome, then think of doing the PKP. If the time or the situation does not allow, then in that situation, you can combine. What is the routine post-operative management? Topical steroids and antibiotics, like what we do for surface surgeries. You don't need anything systemically if it is an autologous procedure, which is the case in 90% of the cases. And what to look for on day one, you want to be very careful when you remove the bandage. The eyelashes are matted, so you want to wet them, remove this gentle debris and open. Make sure that the BCL is present, AMG with explants is visible, and there's no fluid or hemorrhage under the amniotic membrane. Even if it is there, little bit, no intervention required. And the subsequent follow-up, you want to see those explants, amniotic membrane, and BCL. If you lose BCL at any stage before 2 weeks, preferable to replace it, and then after 2 weeks, remove it, stain, do staining, and if there's no epi defect, then you can stop contact lens and continue taper topical steroids, and you can stop antibiotic at that stage. So these are the some of the cases that before and after you can expect the appearance. This is a pre-SLET, post-SLET 1 year follow-up. This is 2 year follow-up. This is 3 year follow-up. This is a patient whom we operated in July of 2011. And look at how the pre-op picture is. This is post-op within 6 weeks or so. And then at this stage, we offered the patient that, cornea is not clearing, maybe we should do a DALC or PK. But patient was not very keen for surgery. He said, I'll rather wait. And this was very early in my evolution of doing SLET. And if you see the patient coming every year and vision improving, in about 4 years, he develops 20/40, cornea is reasonably clear. So what this case taught us that there are mesenchymal cells in the limbal biopsy, which we have documented and published earlier. But here was a clinical example, and that keeps working and they keep clearing the cornea. Based on that, we developed a mesenchymal-based therapy for various ocular surface disorder. And this is one such case. In LVP, we treated a bilateral acute toxic keratitis. And a large number of patients we have treated mesenchymal cells grown in the lab, mixed with the fibrin glue and put on the surface. So this is a potential therapy which I believe is going to change our practice in coming years. And these are different types of indication which I think will be amenable to these mesenchymal therapy. Moran's ulcer, acute chemical burns, or treatment of VKC with mesenchymal stem cells. We are setting up our labs within about another month or month and a half. We will have a lab of functional, and already our other work happens at Ghaziabad, Dr. Dabar Research Foundation. So that we are replicating what I have done in LVP, and hopefully another year or two, we'll have fully functional stem cell lab, innovation center, and a biosynthetic cornea lab. This is an example of a patient with OSSN. If the OSSN is small, less than 3 clock hours, you don't need anything. You can just excise and treat. If it is the involvement, like in the case number 2, is more than that, if you do the excision and treatment, it will always result in limbal stem cell deficiency, and they are more difficult to treat at a secondary stage. Therefore, we started combining as at the time of excision, the SLET along with excision of OSSN, and the results are excellent. Excellent paper published by Swati Kalki from LVP in AJO 2018. Pediatric LSCD, excellent case contributed by Vikas Mittal from Ambala and published in journal Cornea. And if you see how the appearance is, this is the left panel of the left eye of this child, the SLET done. Then over next year and a half, it evolved and the simpliform lease was done. This is another example of a SLET in the acute stage, a pediatric LSCD, a pediatric chemical burn at Vizag LVP and treated with SLET. Then this is a large series we published in 2016 in journal Ophthalmology wherein we had 125 eyes of 120 patients with both pediatric and adult patients, partial and total LSCD. And this is the definition of success and failure. And the success rate was 76%, and gratifying results for pediatric, 71% for children, and 76% for adults. The visual acuity improvement in children and pediatric both were comparable. And another factor we analyze, if you do SLET is done by a trainee surgeon versus a experienced surgeon versus a intermediate surgeon. I think this taught us that this technique can be taught very quickly and reproducible. In few patients who underwent in early stages DALK or PK, we showed that by immune markers, there is a reconstitution of the ocular surface completely. And this technique of SLET is now replicated by independent investigators from India and outside. This is a collaborative study published in BZO 2016 from 3 different countries and 3-4 cities in India. And outcomes were comparable what we reported from LVP in 2016. And then there are further innovations by different surgeons, like customized SLET or top-up SLET, mini SLET for pterygium, a sandwich technique by Dr. Guillermo Amascua from Bascom Bamara Institute. Recently, we wrote a paper which is in print in BZO and should be in press, should be coming out very soon, where we showed that in last 5 years, the number of patients treated for LSCD is with SLET are increasing, and the publication also increasing exponentially. And this is comparison of different techniques, CLET, CLAW, and SLET. Very comparable outcomes, but however, the number of eyes treated with SLET and CLET are much higher than CLAW. When you compare the 3 different techniques, the SLET, CLET, and CLAW on these 7 different parameters, the SLET scores highest in almost all the criteria. Therefore, this is now a technique of choice. Another favorable point is the cost of surgery. SLET is 1/10 of the CLET, cultivated limbal epithelial transplantation. A technique called holoclar, commercial technique approved in Europe, which is CLET based. Each surgery costs 85,000 euro, which is prohibitively expensive for any market. How the recipient eye heals, the explants, because there are not too many studies, and what we have is the human studies. This is a paper by Vikas Mittal in 2015. He imaged each of a few patients alternate days, and then did staining and OCT, and you can see the healing in about 2 weeks. And this is exactly what we saw, the healing pattern or growth of cells explant in the lab. In the left side panel, you see the cells growing on day 10, they become confluent. Here on day 10 to 12, the surface heals completely with a monolayer. Similarly, if you compare the CLAW and SLET, in a CLAW paper originally by Kent Kenyon, the direction of growth is unidirectional because the explant cut edge of the explant only cells grow. While in a SLET, there is a 360 growth, 360 direction or the multi-directional. So the healing is much faster. So these are different factors like which we believe that these implants or these explants are mini limbus which are transplanted. They have mesenchymal cells, they have exosomes which are secreted, and these explants stay longer on the corneal surface. Therefore, they contribute to clearing like the mesenchymal cells. This is the high definition ASOCT of the healing phase in some eyes. And you can just see how nicely the epithelium spreads. And about day 8, it becomes more thinner, and then it becomes stratified. And by 6 months, you may not be able to distinguish whether this patient has undergone surgery. So in summary, SLET is a very effective, replicable, repeatable, affordable, reliable, and open platform technology for the treatment of limbal stem cell deficiency. And thank you very much for kind attention.
Thank you so much, Dr. Sangwan. This was a wonderful talk, and I've had the good fortune of hearing it in last so many years. We have learned from you so much. I just want to ask you, for the benefit of our Noida Society members, how soon would you advocate SLET after acute chemical injury?
If it is a pediatric patient, Uma, I would recommend that you do immediately instead of just doing the amniotic membrane. After cleaning up the pediatric patient means less than 6 years of age.
All right.
Within the embryogenic age group. If it is a more than 6 years of age, then I would wait at least 6 months till the epithelium and the surface heals, the inflammation goes down, and then you can plan. And during this time also, you should try and make the surface heal faster, because what we have seen, if the pannus forms on the cornea remains happy and clear. It doesn't get vascularized. If there is a persistent epithelial defect, then you get stromal scarring and thinning, which can compromise the vision in the long term.
Why do you do it so early in pediatric age group, Dr. Sangwan?
Because as I showed you, our experience of a very large number of pediatric LSCD, almost 40% of our more than 2,000 patients we treated with the SLET were pediatric LSCD, and their success rate was around 40% as opposed to 78% in adults. So the SLET, we were following the dictum in the literature that you wait, let the surface heal, and then only do the surgery. Even when you do this such, the patient go into deep amblyopia. So they may have a treatment outcome good, clear cornea, but the vision is, opportunity is lost. So I would, and also I don't think there is a very good evidence which tells you that you should not do in the acute phase. Now increasingly in our ocular surface community, we are increasingly doing SLET in the acute phase in amblyogenic age group.
Okay, that is within 1 month or within 2 weeks? What would be the
whenever the child presents?
Okay. And in bilateral cases in children?
Bilateral children also I would follow the same. If I'm doing a SLET, I would use immunosuppressant and I will take the tissue from one of the parents or the siblings.
I see. Okay. And what would be your paradigm in treating acute chemical burns, Dr. Sangwan, like in grade 4, 5, and 6? What would be in adults? What would be your line of management after the acute phase when you are treated medically?
In the acute phase, my medical treatment would consist of systemic steroids orally and amniotic membrane, topical steroids, and I would want the surface to heal within 2 weeks, 3 weeks. But if it's 5 and 6 grade, it may not heal, and you may have to do the repeat amniotic membrane and excise the tissue. Excise the dead and necrotic tissue when you're doing the amniotic membrane. Just putting the amniotic membrane, I see people referring patient where they just stick the membrane on the surface as it is. It does not help unless you remove the dead necrotic tissue, induce bleeding, and because once you induce bleeding, that's where the viable tissue is. Otherwise, the healing will happen with secondary intention, which means that there will be a lot of fibrosis, necrosis, infection, and scarring.
Okay. Dr. Goyal wanted to ask something. Dr.
Dr. Sangwan, one thing is that these patients, they do have some symblephrone. Majority of the patients with alkali burns, they will not be they will be having some blephron anterior or posterior.
Yeah.
And will you like to treat them at the same sitting, or there should be 2 sittings, one for symblephrone and the other for SLET?
So if it is a mild to moderate kind of a symblephrone, which is not very extensive, I will treat at the same time. Excision, and if required, you can use the conjunctival autograft at in the site of the symblephrone. If it is extensive, I will treat in the 2 stages. first treat the symblephrone with the conjunctival autograft from the same eye or from the other eye.
And in the 2 stages, first you will treat symblephrone or SLET?
First symblephrone.
First symblephrone.
And at that time, I won't touch the pannus on the corneal surface.
Secondly, these patients, they do have some sort of dry eye, because majority of the scarred corneas, they may not have a wet eye. So do you think that even in dry eye, one can give a try? Or you
No,
might have
if the patient had chemical burn,
yeah.
And in my experience, I don't think that the dry eye is a major issue because of the chemical burn, because it's a one-time injury. So I don't do anything special except using lubricants in the post-operative period. If it is a dry eye per se, and you don't know the cause, I would not do SLET.
Okay.
So if it's a clear chemical history, history of injury, then doing, even if the eye looks dry, I don't worry about it. It will respond well to the treatment.
You have mentioned that acid burns and alkali burns, the outcome is better in alkali burns as compared to acid burns.
Yes.
So what is the cause, main etiology? Why the acid?
Chuna injury.
No, okay.
Lyme is chuna injury. The reason why it better
acid burns are more
see,
poor.
in the literature, I somehow feel that in literature things, the way in the books written, that acid causes superficial injury and all that. I think that may be true, but now we are learning from the rabbit model that the histopathology, pathophysiology of the surface burn is very different with chemical, lime and acid. So with the lime, the surface, the burns are not very deep; they are very superficial. So pannus forms quickly, and you can find the plane of insertion of the pannus, and therefore, and they don't develop glaucoma very often.
Okay. And since up to how long you will go on giving immunosuppressants if you are using the
Allograft.
allograft?
I would consider it doing as long as the graft is working, because there's no point doing it for a year or two, because the allosensitization happens and chance of rejection always remains. So I do not stop.
What is your, what do you use for immunosuppression, Dr. Sangwan?
I use 3 drugs: systemic steroid, azathioprine, and cyclosporin oral.
Okay.
Now you can, if your patient can afford, you can change azathioprine to this cell sap.
Okay.
Yeah.
Tacrolimus.
And tacrolimus, depending
And
on.
there were some questions that how long would you keep the BCL after SLET?
Uma, I think
generally
it's
2 weeks.
Sorry?
Just one second.
Yeah, go ahead. Go ahead.
Sulbi,
Yes, Ajay?
I would, Sir, Dr. Sangwan, we have Jyoti Batra, Dr. Hafza, Sulbi Dutt, and Sridevi, who are cornea specialists, and I would like them to use this opportunity of clearing all their doubts. And I would like all of them to put their video on so that we can at least see their faces in this pandemic. We don't want to have just voice control. We want to even see your faces, please.
Hi, sir.
Hi, Jyoti.
Don't
sir,
see your face.
अभी तो सुरभि आ गई.
हाँ, sir.
हाँ, बोलो.
So, after SLET, once we take out the tarso and the AMG is already gone, how long would you keep the BCL for the explant, sir? Because they take almost 6 months to actually.
Once the end point for us healing is after 2 weeks, you remove the BCL and put these fluorescein. And if the surface is healed, then don't need. If you have a tarsorrhaphy, if it's a pediatric patient, then there is no need to remove the BCL, because the BCL does not really cause harm. So you can keep it for 4 to 6 weeks. When you're removing the tarsorrhaphy, you remove the BCL. And when you have BCL in place, please keep using prophylactic antibiotics.
Sir, and when you have a case of a simple SLET, and you operated and everything, in case we have to do a DAC, because sometimes we have to keep it as a standby tissue. So when you do both DALC and SLET together, then do you tell people that we need to give them oral steroids, or is it all right to just give them topical and continue
No,
the same treatment as?
no. If it is an autologous SLET and DALC is obviously allogenic, but I don't need systemic treatment for that at all.
Okay, okay.
With the success rate which you have shown, would it mean that your dependence on donor cornea would needs will be lesser than they were before?
Sir, yes, meaning like I give you the context. When I was doing CLET from 2001, for next 10 years, I did almost 1500 cases of CLET, and the surgery post CLET, the PK and DALC rate was about 25%. So 1/4 of them would needs one of these procedures. After SLET, this rate has gone down practically zero. I haven't done PK or DALC in last 7-8 years following SLET. So
That would be a
definitely,
good thing.
I think it will reduce the dependence on the allogenic donor tissue.
Dr. Sangwan, I don't see many of such presentations being a retina specialist, but I was mesmerized, especially by the surgeries where you had those bad cases where after all the dissection, the cornea comes out. So I have a simple question. When you're evaluating, this is for the general ophthalmologist. So how do you know that this cornea, you're able to measure the thickness of the cornea before you go in? So you see what is the integrity, do an UBM before you select a patient?
See, you can do UBM, you can do ASOCT, and then now the technology of ASOCT has improved. But when I started, I didn't really have most of those things. So I just went with the hope, and most of the time it turns out okay. And secondly, with experience, the surface pannus appearance can guide you. Like if you have a thin pannus, which is very mobile, gives me indication that underlying cornea is going to be good. If it is a very thick pannus and irregular thickness, very fleshy, that means the burn, the severity of the burn was much more severe, and there is a high compensatory reaction of the surface tissue, which is trying to make up for the lost volume, and you may encounter problem. So if you are a beginner, you must do all these things so that you are sure, because you don't know, and every surgeon is different, that many people are not able to deal with uncertainty. They want to know exactly what I'm going to encounter. But in surface surgeries, you cannot predict all the time that you are going to encounter.
Jyoti, you had a question?
Yeah, sir. Good evening, sir.
Good
I
evening.
wanted to ask that if we've selected our case well, like if it is a unilateral, wet looking LSCD with no adnexal problems, what can be the causes intraoperatively that can lead to the failure in a case of SLET? Are there any operative factors that can result in a failure?
Operative, yes. If you have not taken the biopsy, if you're not gone deep enough, if your biopsy is very superficial, or if you took inadequate biopsy, means the size was smaller, so your number of explants is less. Third, if your residual bed is not good enough, I would say at least 300 microns. Because if your cornea is very thin, then there is a interaction between the epithelium and the stroma, and if they talk to each other molecularly, the stroma says to the epithelium, I'm not able to support. So therefore, the penis will come back again.
Okay.
And that's where you may want to do if you're not very sure, you may want to do intraopachymetry. But generally, with experience, you will be able to judge your depth, your thickness of the cornea.
Okay. And how do you assess the depth of at the limbus? Is it with the experience?
The videos I showed, if you follow the anatomical plane, like if you start dissecting from the cons, say 4 or 5 millimeter behind the limbus superiorly, and then keep dissecting the soft tissue, the Tennant's capsule adhesions to the sclera, and then when you reach the limbus, you will know when you reach the limbus, because the limbal arcade vessels, when you cut, they bleed profusely. So at that stage, you tell your nurse or assistant to continuously put water with a syringe, with a cannula, so that you dissect as if you're dissecting in the rain. Meaning you should be able to be comfortable doing dissection with the water continuously being poured. Cautery won't help, and it will be detrimental if you do cautery near that area. And then follow the insertion of the limbus into the clear cornea about 0.5 millimeter.
Right. Thank you so much, sir.
Good evening, sir. I also had one question. Sir, in case of a chemical injury, what you suggested was that even if it is a 360-degree LSCD and the central visual axis is clear, not to intervene for a SLET?
Yes. If the patient is happy with the vision, and if he is not cosmetically bothered by the appearance.
And sir, what would be your take for cyclosporin or tacrolimus ointment in such cases?
You can use them, but it's not going to help much. So see, the idea of doing the surgery is do it only when it is essential.
Okay.
Don't do surgery to prevent something. So say, for example, if I can enjoy my eyesight with my own tissue for a year or two before it breaks down, and the outcome will be 80% chance is very good. So do surgery after 1 year. If patient says, well, I don't like the appearance, it looks very ugly, both eyes don't look equal, then it's fine. That's a good indication to do the surgery. In that case, don't remove the central epithelium. Try to preserve the central epithelium, because that will also act as the transient amplifying cells are dispersed throughout the central cornea. So whatever normal looking epithelium, that island will also act as a additional source of regeneration.
Sir, I had a question. Sir, if you have a symblepharon and we do SLET with the combined with that, at the point where we have released the broad-based symblepharon, would you want to put the explants more there? Does that prevent, or just the clag would actually keep it away more? The SLET will not really work for the symblepharon to come back.
No, the SLET part would not work very well. The clag will work better. So the difference is, clag is conjunctival autograft, means that it is a formed epithelium, well epithelialized surface. So the symblepharon always forms when you have two raw surfaces opposing each other.
Yes.
So the chances of it coming back are less if the epithelium on the tarsal side is intact. But if the burn was deep, and if you don't put clag or extra SLET pieces there, then the chance that it will recur is very high. So I would do both. In that area, I'll do put one or two explant extra, and then also put the clag.
Sir, I have a photo which I wanted to share.
Yeah, please send me by WhatsApp.
Yes, sir, I'll do that. Okay.
So
and please, for that matter, anyone of you who want additional material or need opinion for a patient, please share on WhatsApp. I'm fairly quick. Within few hours or within a day, I will be able to respond.
Dr. Sangwan, I actually had a question, a non-cornea question. So you just mentioned that
तुम दोनों ज्योति साथ साथ देख के अब समझ में आया. मैं बहुत.
हाँ sir, हम दोनों we are the source of chronic confusion. हम अभी इकट्ठे हैं. Hello sir.
Hello.
So in this hospital, I became Jyoti Batra Ori so as to avoid the confusion.
And so both of them are Jyoti Batri. So what I was sending WhatsApp of one to another. I was getting confused. Still, Uma helped me out.
Correct. So I'm officially only in the hospital. I'm Jyoti Batra Ori to avoid any confusion. Everywhere else, all passports, all documents, I'm still Jyoti Batra. So, sir, I actually wanted to know a simple thing. Just like you said that if you have two raw surfaces, they will stick to each other. We have an extensive symblepharon. So symblepharon release, kabhi-kabhi, it comes to me. So wouldn't, you said you do conjunctival graft only. Wouldn't the conjunctival graft be insufficient? Like if you line, we can line the bulbar surface with the conjunctiva. Yeah. But won't the tarsal surface also require a mucous membrane graft?
नहीं, वही तो मैं बोल रहा हूँ ना ज्योति कि आपको एक तरफ आपने वेल फॉर्म्ड एपिथेलियम लगा दिया, तो
ठीक है।
दूसरा जो एक एपिथेलाइज सरफेस है वो दूसरे रॉ सरफेस पे नहीं चिपकेगा।
हाँ नहीं चिपकेगा, बट उसको रॉ छोड़ना ठीक है, उसको एक को
रॉ छोड़ना, आई थिंक इफ यू हैव सफिशिएंट tarsal conjunctiva around it, it will heal. If you are worried, you can use, instead of mucous membrane graft, you can put the amniotic membrane graft with the fibrin glue.
अच्छा,
Because I want to keep the mucous membrane graft as a second option if this technique fails.
correct, because I used to always then cover the tarsus with the mucous membrane graft and allow the scar or the conjunctiva to fall back on the bulbar surface. So it's okay to leave one of them as raw and the other with. Okay.
Yeah. So now we are starting me and Seema have started a ocular surface plasty fellowship. 3 months for the cornea and plasty fellows.
So even the retina surgeons can join?
Retina surgeon, they can start doing a SLET with the retinal holes and taking a biopsy from the peripheral retinal periphery and start treating the holes, close the holes.
No, we are closing with the laser, sir. Happy with that.
अरे लेजर से क्यों जलाना है? Biological करो ना.
I agree. So thank you very much, sir. If you don't have any questions, we would like Dr. Sangwan to stay on for the next presentation. We have 3 case discussions which are very interesting. We're starting with Dr. Shahana. You're there? Yeah, great. So Dr. Shahana Majumdar would be, since Dr. Sangwan has to leave, I would like him to be, if all of you do not know, Dr. Sangwan was one of the founder members who started the Uveitis Society of India.
I still practice uveitis.
Yeah.
Just don't talk about it.
Yeah, so we want him to stay back at least for Shahana's talk. We have 3 talks. Dr. Shahana would be talking on about uveitis. So let me introduce Dr. Shahana. She did her MBBS and MS from Maulana Medical College, did a retina fellowship from Aditya Jyot Hospital, and she's practicing as a senior consultant of vitreoretina and uvea at IK Hospital. And she's very practical, down to earth, and would be talking on very, it will be very useful for all the attendees, the information which Dr. Shahana is going to share with. So I will not come in between all of you. Dr. Shahana, we have Dr. Professor Goel, who is going to be with me chairing the session. So Professor Goel, can we have Dr. Shahana present?
Yeah.
Dr. Shahana, please.
Sure.
So can you see my slides?
Yes,
Yeah.
Shahana. Yeah.
Okay, I'll just go to slideshow. Okay, good evening, everybody. And my presentation, in contrast, is completely lo-fi, completely disorganized, just stray thoughts on the uveitis patients that I see in my OPD. So pattern recognition is still, uveitis practice still relies heavily on pattern recognition. And if we familiarize ourselves with these patterns, half the job will be done. The slide is not moving.
But we can see the slide.
Yeah, but it's not going forward. So let me try here. Yes. So I'll start off with one such pattern. Suppose we have a young patient who presents with unilateral floaters off and on for a few years, and now he also has diminution of vision. On examination, we see multiple small to medium-sized keratic precipitates all over the cornea, maybe some iris nodules, a significantly present complicated cataract, some vitreous cells. So all this definitely sounds like an anterior and intermediate uveitis, doesn't it? Which obviously needs investigations, obviously likely to need oral and periocular steroids. But on a second look, let's see. This person only has unilateral uveitis. The eye always remains white. There is hardly any circumcorneal congestion. He does not complain of pain. The capes are all over the cornea, not just in the bottom half, and they're somewhat stellate. And in spite of all this inflammation, he doesn't have any posterior synechiae. And the cataract is very, very early for the viciousness of the uveitis and the duration. And if we look very carefully at the iris, we might even see clues such as a peculiar moth-eaten appearance. And the vitreous cells may not really be cells. They may actually be large debris-like things. And in spite of so much vitritis, there is no cystoid macular edema. So we could possibly be dealing with something called a Fuchs uveitis. So very, very often it's mistaken for an intermediate uveitis. I find that they're extensively investigated, is extensively treated with steroids, oral, periocular, sometimes even AKT. And with all these steroid usage, there's always a glaucoma because these patients are very, very prone to glaucoma. In fact, the reverse, they need absolutely no treatment and they do very well with cataract surgery, for which we don't have to quieten the eye at all, except we must warn them that the floaters are likely to continue. The commonest uveitis entity that we see in our OPDs is, of course, the HLA-B27 related uveitis, or the seronegative spondyloarthritic. And this is typically will be a young male presenting with acute onset uveitis, very, very symptomatic. In fact, I'd like to raise a point here. Sometimes they come with symptoms before we see signs, and I've seen doctors miss it entirely only to find that the patient presents with severe pain the next day and lots of signs. So just be wary of that. The uveitis is always unilateral. Both the eyes are never together, but they can be alternate. Fibrin is a big clue. Hypopyon is another clue. And there's a tendency for early posterior synechiae to form. They may even have backaches or be associated with psoriasis or an inflammatory bowel disease. Now, the test here that we need to do is just an HLA-B27, which ideally should be done by the PCR method and not by flow cytometry. And you can also add on a CRP or an ESR to see how much inflammation is going on in the body. There is no need for a MON2 or an X-ray chest, etc., etc. These patients may need a rheumatological referral if there are systemic associations, or for the eye, if you would want to start immunosuppressants if the episodes are very, very frequent, about more than 3 episodes per year. In the treatment, a few points that I had in mind is that mostly we can get away with just topical treatment, need very, very frequent topical treatment at times, even 1 hourly. It's better to give atropine if there is fibrin, or else you can continue with just homide. Sometimes I like to give midricaine so that in front of me, I can see that the posterior synechiae have broken and the eye is on its way to some sort of recovery. Also, it's better to tailor the treatment, first quiescent the eye and then taper rather than a fixed 6-5-4-3-2-1 regime. There are no need for antibiotic drops, and you really don't need oral steroids in most cases. The other phenotype that I want to talk about is hypertensive uveitis. Now, in anterior uveitis is usually associated with a lowered intraocular pressure. But if at presentation, the intraocular pressure is high, and we should be sure that the patient hasn't used steroids because then it might be a steroid response, we would label these as hypertensive uveitis. And it really helps to identify this entity because it narrows down the etiology immediately and becomes more likely to be of a viral onset, or sometimes with sarcoid, or sometimes with toxoplasmosis. And then we can look for other clues such as subtle corneal scars, corneal sensation. The KPs may be pigmented, which is very commonly seen in a viral uveitis. Subtle iris atrophy or frank iris atrophy may also be present. Now, this raised intraocular pressure is because of associated trabeculitis. And here, topical steroids are an absolute must. Some people tend to hesitate to give topical steroids, thinking that a steroid response would make the intraocular pressure higher, but it's just the reverse. The topical steroids will take away the inflammation from the trabecular meshwork and bring down the intraocular pressures. Of course, you have to give anti-glaucoma medications. And nowadays, if we are, sure that it's more or less viral, either by PCR or just by the clinical look, we do add antivirals as well. Always dilate these patients and see the fundus to look for the dreaded acute retinal necrosis, which can be hiding at the back, or signs of toxoplasmosis or sarcoid. In fact, I'll take this opportunity to say that dilate all anterior uveitis patients so that you don't miss entities like a subtle vasculitis or a subtle optic neuritis or a neuroretinitis, or even a patch of retinitis or subtle choroidal tubercles, which will immediately give you a clue as to what's going on. We should also learn to distinguish between a retinitis and a choroiditis. A retinitis will be whitish, more superficial. There'll be overlying vitreous cells, whereas the choroiditis will be deeper, creamy, yellow with the vessels going over it. And the need to differentiate it is because retinitis tend to be infections much more often than choroiditis, such as toxo or viral, candida, syphilis, endogenous endophthalmitis, at which point we need specific antimicrobial therapy and steroids may be disastrous, whereas choroiditis represents a different set of entities. A word here about syphilis, which is now surprisingly rising. In between, we hardly ever saw a case, but now we really do come across these cases. Syphilis can be a great mimic, and it's better to order the syphilitic test as a routine for most uveitis. And it's better to do a treponemal test, namely the TPHA, which is fairly cheap, rather than just a VDRL whose sensitivity is not good enough. Now, when we come to prescribing tests, I see a lot of tests for systemic vasculitis, such as ANCA, CNP, ANA, and even RA factor written for uveitis. Actually, these are more helpful in patients who have scleritis rather than uveitis, where they are a very rare etiology. Even for retinal vasculitis, we really don't need to look for systemic vasculitis. Only in very, very rare situations, there are a horde of other causes which cause retinal vasculitis. And viral serology also really has no role in diagnosing viral uveitis because IgG is present in almost all patients. And even an IgM is rare to get and may not necessarily mean that the uveitis is viral. Similarly, for toxoplasma serology, it may be useful to possibly just rule out toxoplasmosis, but its positivity certainly does not rule in a toxoplasmic uveitis. Well, coming to the Pandora's box of tubercular uveitis, I'll just touch upon it. The steps to diagnosing a tubercular uveitis is threefold. First, and the most important, is that the phenotype of the uveitis should be commensurate with tuberculosis. The second is that we should rule out well-known entities which we know not to be tubercular. And then, only then, do we go on to the ancillary tests, which at best can only support the diagnosis. Now, the signs which are strongly suggestive of tubercular uveitis are, of course, choroidal granulomas or abscesses, a multifocal serpiginoid choroiditis, which is very, very characteristic, large vessel occlusive vasculitis, or a granulomatous anterior uveitis where the posterior synechiae are very broad-based, or chorioretinal atrophic patches along the vessels or vessels with focal constrictions have been found to be signs which are very, very sensitive for tuberculosis. Conversely, other well-known entities like the Fuchs and the HLA-B27 and the viral as far as anterior uveitis is concerned that we just discussed are not tubercular, as are not something like this, where the patient obviously has a toxoplasmo retinochoroiditis, or like this, which is a CMV retinitis, or like this, which is a VKH. Also, we should not mistake an AMPPE for tuberculosis, or a PON, or a PIC for tuberculosis. These are well-known entities, and we should be very, very sure we are not dealing with this rather than a tubercular case. Even a sarcoid, where there is skip vasculitis, an early disc edema, or small patches of chorioretinal atrophy is much more likely to be a sarcoid rather than tuberculosis. It's only after we've done all this that we look for supporting evidence of our diagnosis, and we prefer a MON2 rather than an IGRA in endemic countries like ours. We look for evidence of old tuberculosis, either with a history of contact. We prefer to do a CCT or an HRCT of the chest, and nowadays I include an abdomen also, and certainly avoid an X-ray chest, which is not only not sensitive enough, but leads to needless exposure, and we may have to resort to a CT scan. Then, if we are lucky, we can get tissue evidence in the form of a PCR from the aqueous or a vitreous biopsy, or from the lymph node via EBUS, bronchoalveolar lavage, etc. Now, these signs are not suggestive of tubercular uveitis alone. They have to be commensurate with the signs that we see, which should suggest tuberculosis. My last few slides, I want to talk about immunosuppressants. So the best immunosuppressants are steroids, and most of the others are used as steroid sparing in conditions where we require long-term immunosuppression. Now here, this is a young boy who came to me quite some time ago. He was one-eyed, and we finally made a diagnosis of Behçet's disease and had barely controlled him on azathioprine and steroids. And you can see the amount of steroid toxicity that he's suffering from, when he had a severe recurrence with panuveitis, hypopyon, vitritis, retinitis, vasculitis in his only seeing eye. I gave him multiple IV methylprednisolones and found no response. when luckily for me, this was in December 2014, the Indian biosimilar of adalimumab became available at an affordable price. And this is what came to our rescue. After 7 months of continuing biologicals, azathioprine and methotrexate, the steroids we could taper off. And even after 6 years, this is what he looks like, and his steroid toxicity has considerably reduced. So the absolute indications for immunosuppression would be conditions which are likely to need long-term immunosuppression. And it's better to start the immunosuppression as soon as we diagnose them, because they take 2 or 3 months for their action to come on. Now, these entities would be a Behçet's disease, sympathetic ophthalmia, a severe Vogt-Koyanagi-Harada syndrome, and a scleritis which is associated with systemic vasculitis. The relative indications would be a JIA or seronegative spondyloarthropathies, or any severe refractory or recurrent uveitis for that matter. And most commonly, that would be a sarcoid-associated uveitis. And even a paradoxical worsening in a tubercular uveitis, we tend to harp on immunosuppressants. In the West, they use it for serpiginous choroiditis and birdshot choroidopathies. The last slide I'd like to emphasize on use of immunosuppressants in children. So they may be JIA, they may be HLA-B27, or they may be sarcoid, but we all have to keep a very, very low threshold for immunomodulatory therapy in children. Now, this is because we can't use too much of systemic steroids because it affects growth. We can't even use too much of topical steroids because they will get cataract and glaucoma. And remember, in children, we may not be able to put intraocular lenses, as that does lead to a prolonged chronic inflammation to continue. But on the other hand, we can't allow the inflammation to continue, because if it is inadequately controlled, these eyes very rapidly go into hypotony. So early immunomodulatory therapy is a must. And any child who needs more than 3 drops of steroids per day to keep the eye quiet must be put on immunosuppressants. And the eyes must really be quiet. There should not even be flare. So these are the commonly used immunosuppressants: methotrexate, azathioprine, mycophenolate, cyclosporin, which we've used for decades, and the biologicals, which are like fantastic and giving wonderful results. But we need to be familiar with all of these, and it's best to prescribe them with the aid of rheumatologists. Thank you.
Thanks a lot, Shahana. That was absolutely fantastic, wonderful. I think everybody would have gained a lot. Dr. Sangwan, any comments from you, sir?
No, fantastic. Sana, are you in any way related to Sabrina Shah Majumdar?
No, sir.
Really?
Very non-academic question.
Yeah, because मैं बहुत confusion में हूँ. दोनों एक जैसे ही दिखते हैं. मैंने कहा बहनें हैं क्या?
Please give me her number.
All right. The point about uveitis, I think you made an excellent point about the pattern recognition. And that's not only in uveitis, I think in the human diseases, the pattern recognition is the key for diagnosis, rather than, these academic signs, symptoms we talk. As you get more experience, the pattern recognition is the key for diagnosis. And the way you have put out the different patterns, I think is very, very critical for clinicians and general ophthalmologists, because FHC is most of the time diagnosed wrongly, treated with systemic steroid, vitrectomies, given transseptal injections and whatnot.
Absolutely. Even anti-tubercular therapy, as I mentioned.
Yeah. I think pattern recognition works in any field. When we were students, we were taught that the moment patient walks into your clinic, you start examining the patient. All that is part of pattern recognition, not even in ophthalmology, but every branch of medicine, it's required. So I had a question, Shana, that how much of local steroids, like an intraocular implant or Zudex, or you use? Or
lots of it. Sarcoid, tuberculosis is very common when I get a paradoxical worsening. I'm very, very fond of it.
Yeah. Okay.
I think the first part of your lecture, it has refreshed my memory that we certainly had missed a case or two and diagnosed as open angle glaucoma and even treated one eye. But always we were worried why it is only in one eye. Later on, we found that it had turned out to be a anterior uveitis.
Right.
So that opened our eyes that in future you must exclude this condition before you treat, especially in younger patients.
I think
And
we've all
luckily
made
at
those mistakes, sir.
and luckily at that time, glaucoma surgery was the first choice, not on medical treatment. And we hadn't done it on that eye. Otherwise, it would have been really losing that eye forever. So I think one must have to be careful in young patients who have come with high intraocular pressures.
So for others, let me introduce Professor Goel. You know, he's a well-renowned squint specialist. All of us have, I personally, you know, there was a time when I was doing a lot of squint work, though I don't do any more now, and I learned a lot from him. And I even was a co-guide in squint with him and with some PGs many years back. So
I can help you at this time now then.
Everybody
Shahana,
talks, sir. Why talk?
yes. So Professor Goel, sir, you have
Yeah.
any questions for Shahana?
Shahana, one thing is that the Behçet's disease is less common in India, but there are countries where there is a national
Turkey.
program on the
Turkey.
Behçet's disease.
Yes.
Turkey and Japan.
Silk route.
Behçet's disease, they have a national program for prevention of blindness,
Right.
in which they have included Behçet's disease. Now,
But in
one thing
Chandigarh,
is,
they see a lot of cases, sir.
No, but I think it's underdiagnosed.
Exactly.
yeah.
Incidentally,
Secondly, now uveitis, in uveitis, you say that on one side we are saying that steroids, they will open up the trabecular mesh. On the other side, you are saying that the steroid might induce glaucoma.
Yeah, double-edged
So,
sword.
if so, whether it should be given or not?
it should be.
So if it is there, if the pressure is high when the patient presents with uveitis, then it's obviously trabeculitis because the steroids have not been put. So I'd like to emphasize that on day one, before you start steroids, please measure the intraocular pressures and you have your answer.
No. If the patient comes to you, a fresh case of uveitis cases, they usually have either normal intraocular pressure or lower.
Correct.
And you start steroid. So even if the tension is high, will you stop steroids?
So you will measure the IOP before you start the steroids, no?
No. If the uveitis is there and the tension is high, so will
Yes.
you like to continue steroids or you will stop?
Obviously, you will continue, Dr. Goel.
So, uveitis,
you will jack it up actually.
No, I think Professor Goel, what he's trying to say is if the patient walks in for the first time and you have a low pressure or a normal pressure and you're treating with
and even high pressure,
then obviously the pressure goes up later on, then it may be steroid induced.
Yeah.
That means that though the inflammation is controlled, it's a steroid induced pressure.
Correct.
But if the patient walks in for the first time, has inflammation and the pressure is up, then it may be a so I think you will look at the again, as she said, pattern recognition. So maybe you need to recognize the pattern that is a uveitis with the high pressure and trabeculitis is the cause.
Now, what I would like to emphasize is do take the intraocular pressure when they come with acute uveitis before you start the steroids.
But intraocular implants, of course, there were studies going on in RP Center few years back. They were putting intraocular implant, saying that this is the systemic side effects of steroids. They will be, of course, will not be there if you are using intraocular implants.
Correct.
And the dose of intraocular implant, steroid dose also is much less. So they were saying that it is quite effective. And I don't know whether the retina people also might be able to answer this question, because Ozurdex they are using for retina.
No, so we use it for uveitis a lot.
Uveitis.
Do you use subconjunctival decadron and dipomedrol, long-acting corticosteroids still
Less
or
and
not?
less now.
Because we were using it quite often.
We are using that much less now. We're going more for intravitreal.
So,
But we had a trial of fluocinolone implant, and Dr. Sangwan will know about that, which was fantastic. It was like the Illuvian implant where the fluocinolone steroids were released for almost 3 years.
Yeah.
And I enrolled about 12 patients and had fantastic results Dr. Sangwan, I believe you all had a similar experience.
Yes, I had enrolled 50 patients, and I think it was fantastic. Now,
Fantastic.
Dana is coming back, this fluocinolone. I think there is another name.
UTIC.
Huh?
They've called it UTIC, sir. It's available in the market.
हाँ, कुछ तो different name.
UTIC नाम से दे रहे हैं वो लोग.
Duration का and lower dose.
No, but that was Bosch and Lomb.
No, that's Retisert you're talking about.
Okay.
It's another device.
That was long ago and that was not so good.
2001 में हुआ था वो.
Yeah. So I've been using something which is a little different, and I've been using suprachoroidal injection of transdermal. And it has been pretty successful because it doesn't cause cataract, does not cause glaucoma if you are right in the space. So even I have devised an instrument to give transdermal in the suprachoroidal space with a simple 30 gauge needle. You don't need the suprachoroidal device, which is not available in India, which is by Clearside Biomedical. So you could.
No, but there was a trial. Ajay, there was a trial that we have started in LV.
Peach trial, I think.
Peach trial, sir. Yeah. No, but it's actually very effective in uveitis cases. I've had patients
in vitritis, Ajay.
Yeah, vitritis totally clearing up after suprachoroidal injection of steroids.
I think you'll have to take a class for us.
No, I'll show you cases, but I think what we'll do is we'll have a webinar on uveitis where we'll have Dr. Sangwan, you and others included, and I think it will be a dedicated uveitis webinar. I think that would be good. Let's do it, and maybe we'll collaborate with the USI and do something about it. Dr. Sangwan will help us in that.
Yeah, sure.
So should we go on to the Sir Professor
Yes.
Goel? Should we go on to the
yeah.
next presentation by Dr. Geeta? It will be Dr. Geeta is there. I think she had. I just saw. Yeah, you're there, Geeta. Fine. So Dr.
Seen her after a long time.
Geeta, you're muted. Can you unmute yourself?
Yeah. Good evening, everybody. Good evening, sir. Good evening.
So Geeta Srinivasan has a very illustrious background. She is graduate and postgraduate of AFMC Pune, and then she did a specialization from RPC. She is a pediatric ophthalmologist and a squint specialist, and she'll be talking to us on tuberculosis and paralytic squint.
She could have been Lieutenant General by now if she hadn't left Pune, is it?
Thank you.
Because I read in the paper yesterday, someone, Lieutenant General of that era, working as a lady working as Lieutenant General.
Yeah.
Yeah, Geeta. So
yeah, I'm just trying to share the screen.
Yes. Share the screen and yeah.
So can you see the screen?
Yeah. If you can make it in the presentation mode.
Yeah, sure.
Okay. Great.
Yeah. Okay. Good evening, everybody. My topic today is tuberculosis and paralytic strabismus. Now, the reason I chose tuberculosis rather than any specific strabismus topic was because I thought it would interest everybody. Whenever we kind of analyze a case of paralytic strabismus, we are looking at causes like trauma, aneurysm, ischemic causes, which are all too common, neoplasms, which necessitate aggressive workups, undetermined or idiopathic causes like benign intracranial hypertension, migraine, as well as multiple sclerosis, commonly seen, and of course, the all-important miscellaneous category, wherein almost from 4 to up to 30% of cases are clubbed. Now, it is in this miscellaneous category that the infectious causes of paralytic squint are clubbed. Now, when we talk of infectious causes, viral causes generally predominate our thinking. And just to mention a matter of interest, since we see a lot of dengue out here in India, there are some isolated rare reports of dengue associated with third cranial nerve palsy as well as sixth cranial nerve palsy. Unfortunately, though tuberculosis incidence in India is close to 24 lakhs, a little more now maybe, this is 2019 statistics, it's not probably discussed as a cause of paralytic squint as much as it warrants. So when you're talking tuberculosis, CNS tuberculosis accounts for 1% of all cases of tuberculosis. And of these, association of oculomotor palsy is about 20 to up to 30 to 50%, depending upon which literature we are looking at. So what we're saying is almost 1/5 to maybe 1/3 or half of the cases would present with an oculomotor palsy. The third and the sixth cranial nerve are the most frequent. Isolated fourth cranial nerve has been reported, but it's very rare. Now, the basic pathology is a rupture of the tuberculoma causing a basal meningitis. And this basal meningitis leads to cranial nerve palsies, ischemia because of the vasculitis, and hydrocephalus, which can cause increased intracranial pressure, and that could be the presentation. Now, there are two modes of presentation. Either it could be an acute diplopia with or without fever, but more commonly, what is seen is the subacute and chronic diverse manifestations. It could be a non-specific headache, a fever which has absolutely no pattern, mild cough to severe cough, and vomiting. Now, these misleading subacute and chronic diverse manifestations make early diagnosis quite challenging, and delay in diagnosis, unfortunately, can be fatal. With this background, let's see a few cases and then the take-home message. This is a patient of 28 years who came to us with a history of low-grade fever of 2 weeks duration and diplopia of 1 week duration. Evaluation showed us a best corrected visual acuity of 6/6 in the right eye, 6/18 in the left eye, mild congestion in the left eye, which we attributed to a conjunctivitis, nothing more that we found there. We can see the mild ptosis in the left eye, and evaluation of extraocular movements showed us this mild limitation of adduction, that is medial rectus limitation of -1, and a superior rectus limitation of about -1. We can compare it with the other eye. He had an RAPD in the left eye and a papillitis. So with this picture of a fever, oculomotor paralysis, and a papillitis, a VP was done. The VP showed us a decrease in the amplitude as compared to the other eye, 2.25 versus 20.8, and an increase in the latency, corroborating our papillitis. And imaging of this patient showed us multiple rim-enhancing lesions of this nature here with meningeal enhancement. Now, this meningeal enhancement, along with these multiple rim-enhancing lesions here, even in the extraaxial interspheric regions, was opined by the radiologist to be of inflammatory etiology and most likely tuberculosis. So, early detection of these cases, ATT, if it is instituted, it cures most of the palsies, and the outcomes are very favorable. So a patient presenting with a fever, an oculomotor palsy, a papillitis, tuberculosis should probably be one of the diagnoses that we should be thinking of. There's a very interesting study by Lizulian et al. Who analyzed 72 cases of cranial nerve palsy and tubercular meningitis. And what he found was that almost half of the patients presented with an optic neuropathy, and a little more than half presented with the third cranial nerve palsy. And about 1/4 of the patients almost presented with an involvement of 2 cranial nerves. He also found that if detected early, 97% of the patients recovered despite a bad clinical picture to start off with. This is our second patient who presented to us with a diplopia. Retrospective questioning told us that he had an innocuous low-grade fever for the last 4 to 6 weeks. As we can see here, he has a limitation of abduction in his right eye and a lateral rectus palsy, typical. His pupils were normal, anterior segment and fundus were unremarkable. So essentially a chronic fever and a lateral rectus palsy. With this picture, we advised imaging, and what we found was that he had one single focal lesion here with a perilesional edema. This was opined by the radiologist to be of tubercular origin or etiology. This patient was put on ATP. Now, why is it important for us to detect the paresis of the sixth cranial nerve? Is that it has important prognostic implications with a mortality of about 50% if it is detected late. And in case there is a total ophthalmoplegia, the mortality has been reported to be about 60%. Our third patient, this cachectic 54-year-old individual, was brought into my OPD and had to be actually supported by his wife as he walked in because he was so moribund. And his main problem was that his left eye had closed since the previous day. Now, evaluation, as we can see, it's a typical third cranial nerve palsy. We can see the cachectic individual here, and we see the near total ptosis, the limitation of adduction here, the limitation of depression, the limitation of elevation, basically a complete third cranial nerve paralysis. Now, this patient was advised urgent hospitalization and imaging. And I could not see him back again because when we found out about the diagnosis, he had miliary tuberculosis with CNS spread, and he could not be pulled out of it. So with this picture, now, though the incidence of CNS tuberculosis is just 1% of all cases, clinical suspicion is extremely important because CNS involvement is devastating. It can have a high mortality and it can have a high neurological morbidity if it is detected late. Now, when we are looking at stage 1, as we can see, they are all non-specific signs and symptoms. A low-grade fever, a cough, a vomiting, a headache. At this stage, a listlessness, a myalgia, all these are quite difficult to catch and diagnose. Now, in stage 2 is when you have cranial nerve palsies, either 3, 6, and 7 being the common ones. And like we can see here, 20 to 30, and I said even 50% according to some reports, this is a presenting manifestation. So with this being the presenting manifestation, it is quite likely that we as ophthalmologists may be the first point of medical contact for the patient. Our index of suspicion has to be high so that we are able to pick up these cases. We don't start the steroids empirically, tablet steroid, written so that the inflammation goes down, or thinking that it's an idiopathic cause, which would confuse the picture and probably delay the diagnosis. So with this kind of a picture, if we think of CNS tuberculosis, evaluate, advise imaging, and of course, the final treating physicians would be taken into the picture. It is important that we as treating physicians are able to contribute so that there is a decrease in the mortality as well as in the morbidity, and we have favorable outcomes. Thank you.
Very good. I think
Thanks.
he has given a good analysis of everything. One sign which I would say many times we have seen, it is pre-radiological investigations that the patients have some meningitis, they have a marked photophobia and an indefinite diplopia. No particular muscle movement are affected in the beginning, but they are a sign that they have a meningitis and probably a tubercular meningitis. But then, of course, now MRI and other things would certainly clinch the diagnosis. So one has to be careful about such things. Dr. Goel, you were trying to say something?
So there are in the when there is intracranial lesions, actually, especially in miliary tuberculosis, you have to differentially diagnose from cysticercosis, intracranial. because the number of lesions, they will be similar, and they both are round and multiple, and the patients, they do present with papilledema. And how do you differentiate between the two lesions?
So yeah, I was looking up some literature because this, I mean, we're dependent on the radiologist, but what I was reading about it was that there's something called lipid spectroscopic MRI, and that shows up as more of lipid in the tissue there. It reflects the lipid in the tissue in the brain. When we do that kind of MRI, just picked up. That's what I was reading, that will not be seen with the neurocysticercus. And that's some pointer which the radiologists use to kind of differentiate between the two. And that was the thing that they had mentioned.
As far as I recall, the radiologists used to tell us in tuberculosis there are more localized circumference lesions. In cystic ulcers, they are diffuse lesions. But then the differentiation may be difficult. It may be by exclusion. Diet is no factor because non-pig eaters can equally well have cysticercosis and all that.
Even vegetarians also, they may have.
That's what I say. Non-pig eaters would also have it. I had this experience while in Aligarh. But one has to be very careful.
Actually, she has rightly pointed out that multiple cranial nerve palsy anywhere, whenever we see multiple cranial nerve palsy, we have often found out that tuberculosis was the reason.
Yes.
Because in India, especially, so tuberculosis must be kept in mind. We have so many times we have investigated the patient threadbare from very basic to advanced investigations, and ultimately what we found out that the patient was suffering from tuberculosis, especially this intracranial tuberculosis. So that is, of course, it's very common. And of course,
Geeta,
as she has pointed out, the mortality rate is very high if there
Geeta,
are multiple.
I have a question for you. You know, while we were MBBS student many years back, what we were taught was that a patient with a TB meningitis, usually when he walks into the clinic, is very toxic. But you showed a patient, which was the second one, who had come with sixth cranial palsy, who had probably walked into your clinic, was absolutely fine with a low-grade fever and had a small tuberculoma, which was the cause for this. So I think that's a very important thing, that it may not be totally TB meningitis, but even
Yes, sir. It's mentioned that if the patient has TB meningitis, then there's a small window we get to react to the situation. Whereas if it's a focal granuloma, then we get a larger window period to react before, I mean, if at all, you know, if the tuberculoma bursts, then it creates a problem. But otherwise, I mean, the patient is quite well contained and not an issue so much.
Dr. Goel, I recall a patient who had a superior rectus palsy. There was no lesion to find out as to why it is there, and the other muscles of the third nerve were not as affected. And we tried to do some surgery on the superior rectus. I don't recall what we did. We found a cyst in the superior rectus, and we took out the cyst along with some muscle. It turned out to be cysticercosis.
So I think
there was no proptosis. There was no proptosis and nothing else. And we were really surprised. It was an eye opener that perhaps such bizarre things can come up in a paralytic squint also.
But on the other hand, in the Western situations, they don't suspect tuberculosis at all. Actually, one of my close relative, she was the gynecologist there, and she was having persistent headache. They did MRI, and they found that there was a mass lesion in the area of sella turcica. So they opened the skull, and when they sent for biopsy, it was all tubercular.
Which could have been avoided.
It was unnecessarily craniotomy was done for that patient.
So does anybody else have any questions, Dr. Geeta?
That's why we call always skull as a Pandora's box. We never know what is happening where. That was our good saying in that time. Well done, Dr. Geeta.
Thank you very much, sir. Thank you.
Thanks a lot, Geeta. And
Thank you
we'll
very much.
go to the next talk by Dr. Jyoti. She's there. Dr. Jyoti, hi. Can you
Yes.
put your
Jyoti Batra
video
Ori.
on? Yeah. So, Dr. Jyoti Ori.
Yeah.
Yeah. So, Dr. Jyoti Ori again has a very illustrious career. She is MBBS and MD from AIMS. She is an oculoplasty and ocular oncology fellowship from LV Prasad, and her focus is on oculoplasty and managing the lid and orbital tumors. And we are going to hear, this is the end part, the silent bomb, silent orbital bomb. And we welcome you, Jyoti. Thank you for being there.
Thank you, everyone. And this fantastic meeting today, and Dr. Sangwan, Dr. Geeta, Dr. Shahana, we had them discuss extensively about case pattern recognition, and that helps us in identifying diseases early in things which fit into a pattern. But occasionally we find things which surprises, which we sort of recognize by a pattern, but they turn out to be something entirely different. So I'll be discussing something
Maybe better if you turn on your video also, Jyoti.
I can't. So somebody has turned it off. So my video has been turned off. So I tried switching it on, but
Shy of the camera.
Sunil, can you do that, please?
Yeah. So I was told that the host has asked you to start. Okay, so now I can start.
Yeah.
So I'll be discussing one such case.
Your video is not coming, doctor. That's the reason.
Can you see me now?
No, your video is not getting connected.
Okay, just a minute. Does that happen?
Now we can.
Okay, great. So, so we usually see patterns of certain diseases, and more often than not, if we recognize those patterns, we catch a diagnosis early. And that's what we learned through today's, session today as to recognizing patterns. But occasionally there are these surprises which we see where you see a pattern, but what you find eventually is something which is totally unexpected. So I'll be discussing one such case. So we had this 25-year-old male, and he came to us with the prominence of left eye for the past 2 months, and he just had about moderate pain. The eye generally looked quiet. He had proptosis in the left eye. As you can see, the eye is bulging out, and he had restriction of movements in all gazes. He had restriction of abduction, elevation, down, up, elevation. All gazes, the left eye was not moving well, and he had previously also been imaged elsewhere. So his other parameters were okay. His anterior segment, posterior segment. The posterior segment, the disc was healthy because there was something behind the eye. There were a few ileum folds on the macula, but per se the eye was okay. And in the orbit, a firm non-tender mass could be felt in the inferior orbit. And prior to reviewing with us, the patient had reviewed for the same complaint because he'd been running with this complaint for the past 2 months at a tertiary care hospital. And he was diagnosed to have NSOID or a pseudotumor and received systemic steroids for over 6 weeks. And he had some relief in pain, but he was largely the same. The proptosis had remained the same. His imaging had not changed. He had 2 imaging done. The imaging hadn't changed. His movements hadn't changed. Limitation movements had not changed. So this is what the imaging showed. So this is what we felt on palpation also, that in the inferior orbit, there was something in the MRI or in the CT also, which he had around the inferior rectus. And this mass was extending all the way posteriorly into the orbit, into the apex, encasing the inferior rectus. And it was isodense to the muscle, and it was enhancing a bit with the contrast, but seemed to be reasonably well localized. And the other tissues, the nerve could be seen clearly. The inferior rectus is what it seemed to be centered around. And similar thing was seen in the CT scan. There is something happening around the inferior rectus. And that's why maybe he had this provisional diagnosis, and you see these muscles thickened here also, the muscles which are in contact with this lesion. The lateral rectus is also thickened. The lesion is ascending right up till the orbital apex, largely around the inferior rectus, with some thickening of the other associated muscles. and the lesion essentially extending all the way back to the apex. So with this kind of an imaging, one would initially think of orbital inflammations, but he had already, he had already received steroids for 6 weeks, not even 1 or 2 weeks. He had received it for 6 weeks after, an extensive sort of an for an investigation for an underlying NSOID, none of which was revealing anything. He had not responded clinically to the steroids. He had actually had worsening on the basis of imaging on steroids. The other thing that you can think of with such certain things is an orbital tumor and probably a metastasis. But we also did a systemic workup with the chest X-ray, ultrasound abdomen, ultrasound pelvis, nothing, all clean. And so we thought, let's just start fresh. We withheld the steroids, rechecked on things to see if there's an inflammation happening. So essentially, all good, nothing. So we just had a mass in the inferior rectus, and then we planned him for an orbitotomy. Because he'd already undergone a few imaging, he wasn't so affording, so I did an ultrasound for him. To my surprise, this lesion turned out to be a fluid cavity and not a solid mass, unlike the CT and the MRI. The fluid character is actually best picked up by an ultrasound. So yes, it turned out to be a large fluid cavity. And in the center of this, we have this, hyperechoic area. And I thought, oh, is this a scolex? We are in India and we see this, a large fluid, maybe not so large, but a fluid thing with the center, some opacity in the center, in a muscle, around a muscle. Is this a large cysticercus? Is this a cysticercus? Because it is deep in this orbit. So I thought, okay, let's give him another. And then I look back at his imaging. Okay, did I miss a scolex? I'm like, oh, is this a scolex that we are seeing? Okay, then I said, okay, maybe this is cysticercus. And I gave him albendazole with another course of steroid. But after 6 weeks, again, there was no clinical response in terms of his inflammation or his proptosis. He just developed steroid response, raised IOP from the steroid response, and we gave him beta blockers for that. So with him looking the same, I planned to take him for an orbitotomy. So I did a transconjunctival orbitotomy. We went between the lid and the globe into the inferior fornix and raised the periosteum. And when I approached the lesion, opened the periosteum, there was 6 ml of frank pus. Now, this man has nothing in the sinus. When we have orbital abscesses, most often we have something going from the sinus into the orbit. He had nothing in the sinus, and he has 6 ml of frank plus coming out on opening the periosteum. So this was in the orbit and not in the subperiosteal abscess in the plane. We collected the pus, sent it for culture. Now I'm also thinking that just like in India, because it could be a cold abscess because he didn't show any signs of inflammation, and we sent it for culture, including an LJ culture, to see if this could be tubercular, because it could be hematogenous spread, and and it could be a cold abscess. Washed this area extensively with betadine and collected the specimen from the wall with the previous pus-filled cavity. And in 3 days, in all media, there's an unusual fungus called acrimonium which grew in all media, including LJ, blood culture, chocolate agar on LJ, and all media in 2 or 3 days we had acrimonium. Acrimonium is a highly saprophytic fungus, and it's not really been reported in as an infective cause, except with direct trauma or within an immunocompromised host. And our host wasn't, in this patient he wasn't either. So he resolved clinically with pus drainage. The patient was much better. We gave him voriconazole because he was a patient who had a fungal abscess, who had received 12 weeks in total of systemic steroids. And we had to look for an infection. I made him undergo an infective carditis, endocarditis workup also, which didn't yield earlier. But I keep looking back at his imaging at this patient, in terms of a pattern in a fluid-filled thin cavity, to see is there a way that we could have picked it up earlier. And maybe sometimes we end up with surprises that we can't help. because more often than not, when you look at fluid corrections in and around muscles, we're thinking of cystic circus, we're thinking of chocolate cyst, we're thinking of things like dermoid, but we may be a cold abscess, tubercular cold abscess, but occasionally we find surprises. So this was probably something different. Most abscesses also have rim enhancement, which this patient did not have. He had some enhancement, but the rim enhancement, which is characteristically seen in abscesses, wasn't there. So occasionally, even with the patterns, we come up with surprises, and that's what maybe we should keep our eyes open, and we should be ready to face these surprises also. So maybe he had an hematogenic spread from a fungus, which is quite unusual. So we need to keep a cold abscess, and the microbiology team really helped us in picking up these uncommon organisms. Thank you.
Thank you.
Can you answer? Yeah,
At the outset, Dr. Ajay,
yes, sir.
it reminds me of Dr. Gogi, our colleague. You would know, Jyoti wouldn't know perhaps. He was doing mostly orbits. He's no more at the moment in Aligarh. You remember him?
Yes. So
Yeah. And he would always say that diagnose pseudo tumor unless otherwise proved. Is it so, Dr. Jyoti?
No, sir. Actually, the other way around. So the pseudo tumor is the diagnosis of exclusion. So until or unless I can't pick up anything, I don't call it a pseudo tumor. Pseudo tumor is actually like a.
But you put them on corticosteroids and treat them till you are able to find out the cause. Do you or you don't?
So it's actually maybe, where uveitis was 100 years ago. So pseudo tumor is like a wastebasket term, where you still haven't been able
Where
to.
we don't know the cause, yes.
We don't know the cause. Maybe in the next few years, when we have more histopathology, like they come up with IgG4 disease, you would know one from the other. Now it's just a brand. You want to just label it with something, and they don't all behave the same. Dacroadenitis doesn't behave like something around the nerve or the muscle. They all behave differently. I think it's just something that we don't understand well enough, so we just put that label for convenience.
No, I think what Dr. Goel was saying.
No, we took, just a minute, we took muscle biopsies when the tumor, so-called pseudo tumor, was very close to the muscle. Any muscle, maybe of the horizontal muscles, we found a hypertrophy of the muscle mass in those areas, though they were not a continuation of the pseudo tumor as such, not involving the muscle as such. And perhaps he thought some bizarre cause involving the muscle giving rise to diplopia, and of course all other pressure signs due to a pseudo tumor. You have any idea of the muscle status in such cases?
So biopsies that I've done actually haven't shown muscle hypertrophies. Till the few muscle biopsies that I've done, I haven't done a lot, sir. Most of them show inflammatory, chronic, or benign.
Yeah, that's true, yes.
Inflammations. And with all the biopsies that have been collected, some of them with some special stains, for example, honestly, the IgG4 disease is a subset which we, for example, uveitis, the retina people describe Behçet as separate from the something else, they have that spectrum there. So from the biopsy that have previously been collected are being restudied again and again to sort of, tease out one disease away from the other. Even in that vague inflammation that is being seen in most uveitis, just like the biopsy that we would take up, there is a pattern which is sort of coming up. Maybe I think we give steroids to a lot of them, but they all behave so differently. Some of them in 2 weeks, they are like absolutely okay. Some of them would linger for 2 years, 3 years. You give them steroids, you withdraw steroids, they come back to you again. Maybe we still don't. Honestly, I feel that there is a lot more to learn in that particular disease than in some of the other diseases.
Incidentally, who was the plastic surgeon or orbital surgeon when you were a postgraduate at RP Center?
So, sir, I had a thesis in oculoplasty. Dr. Neelam Pushkar was my guide, sir. So I learned.
But you did it at the AIMS, you said?
Yes, sir. Dr. Neelam is at AIMS, sir. Dr. Bajaj was also there, but I have specifically.
I never heard of Neelam, yeah.
No, Neelam Pushkar is well known, sir.
Yeah.
No, I never heard of her.
Yeah.
So she
Okay,
was
so
my guidance.
Jyoti, I have a question. Is that I think what Dr. Goel was pointing out, and this is for the postgraduates, and this is just a message that would you agree that you should not label any lesion as a pseudotumor and give them a test of steroids, but try to find the etiology first, and
Yes.
pseudotumor should be the last cause of exclusion.
Absolutely. Absolutely.
Yeah, because that's what when we were earlier training and pseudotumor, commonly they say, let us try steroids. If it responds,
that's
it's a
what I said,
pseudotumor,
yes.
which I think is not true.
Yes.
No.
Okay. The other thing was in your presentation, you said that the pus came out from orbital side rather than subperiosteal.
Yeah. So subperiosteum is the space between the periosteum and the bone.
Right.
So if you rate the periosteum, the collection, as we saw in the imaging, was not between the periosteum and the bone. It was between the periosteum and was lining around the muscle. So when you open the periosteum and go into the orbit, that's where the pus came out from, which is even a more unusual place for a pus to collect than a subperiosteal plane. So it's
Even without tenderness even.
Yes, he had nothing, no signs of inflammation, nothing. Even his ESR was normal, blood count, everything was normal.
So Jyoti, many years back, when I was a postgraduate, we had a case presentation. There was a patient who eventually turned out to be an orbital aspergillus niger, and he gave a history of walking in puddles of water, and some thorn pricked his eye, and that led to a fungal infection when otherwise he was absolutely immunocompetent. So
Yes.
from then onwards, we started asking this history that whether you were, I think Dr. Ratnam has presented some cases like that because I'm from JIPMA, so we had this in South India, patient presenting like that.
Yes, direct inoculation is a thing that happens, and he didn't have anything like that, not even a minor trauma. So direct inoculation is a known thing for causing acrimonium. Also, there are case reports of large abscesses collections happening with acrimonium. Also, this particular mechanism that grew, and with other fungi also with the direct inoculation. But for a direct inoculum, this was very deep, and there was no trauma, absolutely none.
Professor Goel,
Jyoti,
any questions?
You had an excellent, this was an excellent presentation. I could think only up to cold abscess. Beyond that, I was not able to.
So we were also, when I saw the pus, I was actually surprised. I thought it'll be something funny. I told my anesthetist, I don't know what this is. Let's see kya aata hai. And
What I used to teach my postgraduates, course way back, that if a paralysis of a muscle does not conform to any nerve palsy, consider an orbital lesion first and try to investigate that. Of course, you don't do it now. We were doing venography also at that
orbital
time.
venous. I've done orbital venous.
You must have done.
no, sir, I haven't done.
Yeah, we did it. We did it because I had been in along with strabismus. We've been interested in orbital things also for some time till Dr. Gogi took over. Right.
Interesting.
Good.
So
Nice
I think
presentation.
if there are no more questions, I think we must thank all the presenters. Dr. Sangwan, he's actually had to go somewhere, so we really enjoyed his presentation, and there was a fantastic interaction. And must thank Dr. Shahana, Dr. Geeta, Dr. Jyoti for this wonderful presentation. And I think you would agree that if all of us participate, we can really make Noida Ophthalmic Society a very vibrant academic place where people would love to participate in. And it will be required for us to take the onus and have a monthly interaction. So the next meeting is scheduled on 6th of April. Which is, so we are having alternate meetings. We have a subspecialty meeting on alternate months and a case presentation on alternate months. So next month is on glaucoma. And
second Tuesday, you said.
Yeah, it will be always Tuesday.
Second
sir.
Tuesday.
So 6th of April, Tuesday, we start at 7 o'clock. We have a glaucoma webinar, which will be sponsored, which is for about 50 minutes. It may extend to another 10 minutes. And from 8 to 9, we will have case presentation on glaucoma. And I would love all of you to participate, even if you are not doing glaucoma, because it it really stimulates us to become a good ophthalmologist as such.
Ajay, I had been interested in glaucoma for a long time. And for your information, I had been the president of Glaucoma Society of India
wow.
at some place. It was after Dr. Sood.
Okay.
I was next to Dr. Agarwal, not Sood. Sood and then Agarwal and then myself.
So we'll have you over for the next session, sir.
Yeah. No, I'll be there. You just
Yeah,
send me the
we'll send you
link.
the link.
I'll be there in every session. But send me the link.
Yeah. And please, I would want positive criticism. If there's any suggestions, any remarks, please share so that we can all incorporate those ideas and make this more positive and vibrant.
One good
Thank
thing
you.
I have seen is
Thank
that the lectures were small, concise, and to the point. There was no beating about the bush in any of these lectures.
We don't want that, sir.
Yes.
You convene it very well, yeah, Ajay. Very well.
Thank you, sir. Dr. Atul, he's a president. Dr. Atul is there. Are you there, sir? Dr. Atul, can you, if you are there, I think he just came on. He's actually is busy in his clinic. He runs it late. So anyway, so.
Recently, Dr. Goel, where are you working at this time now? Just
I
sorry
am,
about this. This is general talk.
I am a professor and head of ophthalmology at Sharda Medical College.
Oh, good.
Present Greater Noida.
I had been going there as an examiner for quite some time.
Your
When
name
Mehta
is there.
was there, DK Mehta was there.
Yeah. Your name is there in the list.
Is it?
I just saw.
Yes.
So Professor Goel was actually was my teacher also, Dr. Jawaharlal Goel. And both Dr. Goel, B.S. Goel and Dr. Jawaharlal Goel. And I thank you very much for being there, sir.
Thank you.
And I think, should we call it a day then?
Yeah.
Yeah. Thanks a lot.
Thank you.
Dinner time.
Okay. Thank you.
Post lecture dinner.
Thank you.
Thanks a lot.
Okay, bye.